He was so resistant to the idea of somebody coming into his home to help him. He was so resistant to moving into residential care. And when he eventually did all of those things, it was the best thing he'd ever done. He had a portable seat with his wheelie walker when he'd go and do the shopping. He had somebody helping him with his meals so he didn't have to think about it. But he had to get there in his own time. And I think that that is actually a really important normal part of dealing with change. And that's actually not any different in neuromuscular conditions. So what about the normal changes that we all have to deal with, which are also impacting on adults with neuromuscular conditions? And I think, often people come into the clinic and we focus on the neuromuscular component, and then the GPs can get a little bit overwhelmed with the neuromuscular component. But there's actually all this other normal part of aging as well. So it's things like our teeth. As we all get older, our gums recede a little bit, and that makes our teeth more susceptible to infections, which can impact on chewing. So something like that is a very important part of aging, is looking after our teeth. It's our brain health. We all get micro changes in our brain structure as we age that can affect our thinking and can affect our speed of thinking as well. Our bone health, we've heard so much about that today, and the impact of bone health just from aging, from being less mobile, from being less active, from changes in our diets. And that again affects everybody as we age. Our heart health. As we all age, our hearts and our blood vessels to our hearts, particularly the arteries, they get a bit stiffer, which means that they don't work as effectively unless we do something to help them work as effectively as they could. Our vision, particularly in Australia, with cataracts. So the sun that we have in Australia is an accelerant for developing cataracts, irrespective if you might have a neuromuscular condition that's also associated with cataracts. Hearing, the loud noises that we're all exposed to can decrease our high frequency hearing as we get older. Metabolism slows down as we age, and I'm sure that most people have noticed this. As we get older, we're more prone to putting on weight with the same amount of calories. Our guts slow down because of this as well. And so the changes in our gut health as we age can make us more prone to things like constipation, to not absorbing our nutrients as well because of microstructures that change within the gut. Our bladder and our kidneys, if we don't keep our kidneys well hydrated, then they don't function as well. And then the waste mechanism in our body, so getting rid of all of the waste products from day to day, can be impaired. And our bladders can get less elastic. So even if you don't have your bladder affected by your neuromuscular condition, normal aging can make it less responsive, less likely to empty properly, or more likely to be irritable and need to pee even more. So those things are all normal parts of aging. And then for those of us with ovaries, we've got the added joys of going through menopause, which can also make life a little bit more challenging at times. But every single one of these things that are on this screen is a normal part of aging, that is a normal change that you have to deal with. One of the good things about it, though, is that the things to make these changes a little bit easier are all the same. And it's the things that are really hard, but are also really simple. It's getting a good night's sleep. And I'm going to talk a little bit about that in the role of CPAP and making sure that we've got lung health, respiratory health well addressed. Maintaining hydration, which can be challenging depending on how quickly you can access a bathroom. And I know a lot of people tell me they don't like to drink before they come to the hospital because they hate the supposedly accessible toilets that we have here at St. Vincent's. So they won't drink before they come into the hospital because they don't want to have to navigate the bathrooms. Maintaining exercise, we've heard a lot about that this morning. It's part of bone health, but it's also part of cardiorespiratory fitness, which has overall benefits for heart health, for brain health, for kidney health. It's about having a healthy diet. Something as simple as making sure we're getting enough fresh fruit and veggies helps combat things like osteoporosis. It helps combat things like constipation. And then making sure that we have something that addresses the stresses in our life, particularly having come through COVID. There has been so much more stress and anxiety at a societal level, let alone adding in health needs and some of the anxiety and added stresses that go with having a medical problem that you have to deal with, and making sure that we're getting that social interaction. It's actually really important for healthy aging. But what about when you throw in an additional complexity to the change, which is the changes that we see in neuromuscular conditions. So the graph that is usual, the informatic that's usually put up for aging, we've got, the baby, then standing, then the person, and then the walking frame. Not everybody with a neuromuscular condition will go through that exact process. Some people will be in a power chair at a different level to where we would normally expect walking or gait to decline if you didn't have a neuromuscular condition. Some people will need to go on to breathing support sooner than other people may need to. And some people will end up needing additional carer support to help them with what would otherwise be their normal aging. And this can sometimes happen sooner rather than later. I've got a couple of quotes here from some work that we did towards the end of last year with adults living with spinal muscular atrophy. And I can see a couple of people on the line who did contribute to this group. I've anonymized the quotes, but I thought it was really interesting to show the range of responses to change. So one person said, once you have watched that first significant part of your body that took your independence away, that's quite soul crushing. So there can be that really profound, visceral response to a change when you have a neuromuscular condition. But there can also be a resilience and an acceptance of, I don't care about not moving. My wheelchair is for moving, and that's fine. And that then can allow people to put that to one side and focus on the other things that are important in life. And the three examples I've got of where people really struggle with change, so moving to mobility aids or moving into a power chair or moving across to using ventilatory support or moving to having a carer, one of the key things that all those things have in common is actually decreasing stress and decreasing energy expenditure, because you can delegate that to something else. You can delegate the energy expenditure that goes into walking and moving into the power chair, diverting your energy to something else. You can delegate the breathing effort into the CPAP or BiPAP, so you've got more energy for something else. You can delegate the effort of cleaning your house and moving in and out of chairs and moving across to toilets to your carer. So you can delegate that energy to something else. And that's one of the things to think about in terms of understanding and dealing with change. These are some of the other reactions to change that I see really commonly, and these are again quotes from our focus groups, but things that I hear across the whole spectrum of neuromuscular diseases, and also in other conditions. So I work in stroke as well, and these concepts would be similar across any kind of change. I will look at things and be like, I used to be able to do that. I remember being able to do that, and now I can't. Yeah, it'd be grief and also anxiety. So this concept of a loss and a grieving for the things that you used to be able to do that you can't do anymore. You've got to plan everything and think about them. When you start to think, oh, how are people going to perceive me if I've got to use a walker to go through the shopping centre now? These things play on people's minds. And so the stress and worry and anger can really become a dominant reaction in some of these times of change. And what I see most commonly is people are really wanting to hang on to their independence and their autonomy. And this is a really important element of their well-being. And then having to balance that between increasing health demands and increasing physical dependence that might go with a neuromuscular condition, because the majority of neuromuscular conditions are associated with a decline in function and a decline in health. So that's the reality of having a neuromuscular condition. There's no point saying it's not, because it is. And it's about how we manage that and where the healthcare team can come into helping you navigate that part of the condition. And I've got there, keep calm, I'm not ready yet, because over the years, it's become really apparent to me that I can't force or bully anybody into accelerating change. You have to do it when you're ready. And everybody resists it. I think that's normal. I think it's normal to resist change, but by far, the patients who come back and who've made those changes, and predominantly I'm talking about things like ventilatory support, mobility aids or chairs, and carer support, because they would be the big three that I see that are the changes that really cause stress and anxiety. People come back and say to me, why didn't I do this sooner? But I think you can't get there until you're ready to get there, and that's okay. And I think that's a really important part of my role as a neurologist, to say it's okay. And if it's that you end up in the wheelchair because you pushed on so hard and you did fall and you did have a fracture, but that was your choice and you did it with knowing that that was the risk, but you did it and that was your decision and you own that decision, that's okay. We just deal with a fracture, you know? You can't wrap everybody up in bubble wrap and say you can't live because you might fall over. It's about working out what's acceptable to you as an individual. And then this is I think this is my last slide. And it's really about, I think what makes change successful and less stressful is owning the change and working out what are your priorities and what does that look like. And if your priority is independence and autonomy, is there a way that independence and autonomy also fits with bringing in more support? Because it really can. And I've got a couple of other quotes there, but it's about, I think, reframing what the change means. And does, my loss of walking mean that this is a negative thing, or does my moving into a chair give me more freedom and improve my energy levels? And the same with some of those other examples that I gave. So one person said, I never had personally anxiety going to see the neurologist or seeing someone that is an expert. I've always actually been really excited to have the opportunity to talk about what's happening. So it's that reframing of, I'm really stressed about going to the neurologist because I know I've just declined and I don't really want to talk about it. Or I've got a good neurologist, and I know that's dependent on the neurologist at times, but I've got a good person who's going to support me through this. So I want to go to this appointment because I want to make the changes. I had a patient the other day, not with a neuromuscular condition, but who has cancelled her sleep appointment 3 times because she didn't want to tell the respiratory physician she's not using her CPAP overnight. I said, well, tell me what the challenge is. Why can't you use it? She's like, it doesn't fit me properly. I keep waking up, so I'm not using it, but I don't want to tell him I'm not using it. I'm like, go and tell him he's got it wrong. It's not working. He needs to make it better for you. So it's that reframing. And then, so another person said, I'm not saying we're elite athletes, although at times I'd argue about that, but you've got to look at things because you look in the same way, the same things, because you're looking at optimizing your body. So if we think about ventilatory support, it's not, if we can reframe that to think about, well, I'm just giving my lungs the extra support that they need to perform at their highest level. And I think in that context, it doesn't really matter what I say because I don't have the lived experience. It's also really important to have, I've got the expertise, the medical knowledge, but we've got to tee up that with your lived experience and the peer support, because I think what your peers can support you through things that I can't understand. And I shouldn't pretend to understand some of those things. I can support through it, but I can't fully understand it. And that's where peers can be a really important component in managing change. So I don't know if I went over with my time there, Carolyn, but I'm really happy now to throw it open to any comments or thoughts or discussions. Or Carolyn, I don't know if you want to comment on some of the things that I've mentioned. Oh, we've got a few things in the chat. I'm going to stop sharing.
Yeah, I'll let Joan take it from here, Lauren. My husband said he fell over, so that's why I went out of the chat. So I apologise if I go and check that he's okay. How ironic that he's dealing with change when he's just fallen.
Yep. Is he okay?
Yeah. Okay, so thanks very much, Lauren. Clearly, there are a couple of themes that you've identified in that presentation, some areas of change, and we thought possibly that we might encourage people to focus on some of those areas. So one of them was changes in mobility, and the other one was changes in respiratory support, and also changes with the need to introduce support workers. So does anyone have any comments about their own experience or questions that they might like to share with the group now on maybe one of those topics? Changes in mobility, how people may have managed those changes, or questions they might have in relation to managing those changes?
Yes, I've got a question, if I may.
Yeah.
I have IBM, and while I'm getting around at the moment with the aid of a walking stick, I feel, and I do attend a the ACU exercise classes weekly for an hour. While that seems to be working at the moment, I feel my walking is getting a bit sloppy, to say the least. And I don't think it'll be too long before I've got to think of the next step. Now, where do I go for the next step? Is that through the neurologist or through an association?
Yeah, so I think that the neurologist should be the person guiding this, and we'll often talk about that when I see people. Sometimes it's as simple as checking that the orthotics are right for now and getting in early and seeing a physio and an occupational therapist. It depends a little bit on where you live as to which physio and which OT you can access, or whether you have already had support for that through an NDIS package, or whether it needs to be through a community rehab centre. But thinking about that in advance. So I'll often say to people, okay, we need to think down the track a little bit. Are we thinking that we're moving towards a different mobility aid? Are we looking towards frames? Are we looking towards wheelchairs? Let's get you linked in with the occupational therapist and go and have a look at them. Try them out. It's like buying a new car, right? You're just not going to get what's given to you. You've got to try them and see what feels right for you. And sometimes it can take a little bit of time to get used to something new. But the physios, when they can do those assessments around new mobility aids, can often then go, oh, look, maybe we need to tweak your exercise program a little bit, and let's focus on optimizing this part of your mobility. And so most of my patients will have an NDIS physio who they work with regularly, but also will have an appointment every 6 to 12 months with the neuromuscular physio specialist, just to make sure that the programs are correct for that individual at that point in time. Does that answer your question, Barry?
Yes, it does. Thanks for that. Very
And
good.
can we just throw to you, Sumon? You have a question you wanted to ask?
Yes, thank you. So I guess like the last 3 or 4 years, I've experienced a lot of decline, and like I wasn't sure whether that's just the progression of neuromuscular disease or it's aging. And I'm so glad that I got to listen to you, Lauren, because no one told me that, okay, like this is to be expected, and then the decline may be like sort of double whammy.
Mm-hmm.
So I wasn't sure what's happening. And I didn't have anyone telling me like, okay, like you should. I was so fatigued, I could barely get up from my desk at work. And I had to make a decision about, okay, I have to start using a wheelchair at work and all these things myself. And then when I asked the health professionals, like, am I making the right decisions? It's, you know, is it like sort of giving up? What about like losing more muscle mass because you start, you know, I'm using the wheelchair more? Like people have very different answers. So I found that really challenging. And how do you know that what's normal progression versus abnormal progression?
Because we have to think about both. You're right. It can be like a double whammy. But just because you have a neuromuscular condition doesn't mean that we forget about iron levels, which contribute to fatigue, or thyroid, or heart health. So all of the things that, you know, primary care physicians are trained to monitor for primary health and, you know, health prevention, those things still need to be considered in someone who has a neuromuscular condition. So when there is a decline, there does have to be that question about, can I blame all of this on my neuromuscular condition, or have I suddenly had a decline that's out of character for me? Has something changed that's different? And in that setting, it's worth checking that it's not something else that's a part of aging that's causing it to be worse than it needs to be.
Thank you.
There's a question here. I'm not sure it doesn't have your name on it, but the question asks at the end, how do you get the interim support you need when you're not so bad?
Yeah, do you know what? I think this is actually something that we as a health profession don't do well. And I think it's a really important topic, because we're good at, as you say, we're good at making these discrete changes. It's like ventilation starts now, you know, but what about that lead up? And I think this is where for people who've managed to get NDIS, and I know it's a pain in the bum to get through all that paperwork, but once you get it, It's pulling all those resources to create an individualized support team around you to look at all of the kind of maintenance things. So muscle strength might be good, but what about those subtle things? So like if you are dependent on one finger to drive a power chair, that doesn't pick up very well on a lot of the assessments that we are trained to do in neurology or as physios, but we really need to optimize the function of that finger to continue driving the chair. So I think it's about, pulling that team around you to work on maintenance and working out what are the goals that are important to you, and reevaluating those from time to time, and if it's I want to work on my endurance because I want to write a novel and I want to be able to get to the end of, typing a chapter. Well, how do we optimize all the other endurance things around that and the strength and the muscle function to work on that as a goal? So I think it's individualizing goal, pulling a team around you and working on maintenance, accepting there will be a subtle decline from time to time, and that's okay, but working on what does that mean for you?
Okay. There's a question here. Unfortunately diagnosed in my late 60s, no NDIS, feels like there's no specific support around. I'm looking at a huge change going into retirement. That's been hit with a diagnosis and feel quite lost as to where to get help.
Yeah.
Lauren, I just wanted to say in the chat, I just wrote about the value of peer support, in terms of like getting ready for change. I spent years and years hearing about, non-invasive ventilation and telling myself that wasn't ever going to be for me. And, once that became a medical issue and a directive of medical professionals, getting peer support around that change, getting really good clinical advice as well as practical support at home. Main thing for me was getting my head around saying, instead of saying I can't do this and I'm not doing it, was actually saying, you know what, you can do this. And like that reframing piece in my own head, those were the kinds of things that really helped me at that point.
And I think that, and I was actually going to point that out in that comment. So I think that is one of the really important things. There are two components to this question about, being diagnosed later. And that's tough because I've recently had a patient where we put in the NDIS application. He was 64. NDIS took their own sweet time about it. And he's now 65 or was 59 and 60, whatever the cutoff is. And they've now come back and said, oh, you're too old. I'm like, but we got the paperwork in before he was too old, and now this person's kind of lost and we're trying to go through my age care, which is not the same. It's not set up in the same way. And so again, we've got challenges with the system. And this is really where the state-based organisations have an amazing role. And we do need to look to our state-based organisations for support here. And I really would encourage the peer support, but also talking to your neurologist and letting them know that it's tough, and having a good GP, because a good GP is somebody who can build that relationship with, and they can be an advocate for you as well. And if they're not comfortable with a neuromuscular condition, get your neurologist to talk to the GP. I've had some great GPs in Melbourne recently who've taken on some new patients with neuromuscular conditions that they hadn't heard of before, but we've had a conversation about it and we're supporting each other. They can do all the GP primary care stuff that I have forgotten from medical school, and I can do the neurology stuff, and we work together. So I'd say good GP, talk to your neurologist about those challenges, and link in with your local state-based service so that you've got the peer support. And don't underestimate the power of talking to other people who've been through it, even other retirees. They don't necessarily have to have had a neuromuscular condition to have had the challenges of going through retirement.
Unfortunately, we're almost at the end. I don't know if we've got one last question, but it'll need to be quite quick.
Or a comment.
Andrew might have some really useful things to say in this space. And I know I asked him especially to come into this session, so I'd love for him to have a minute to talk.
Yeah. Andrew, are you there? Have you got a comment?
Can you hear me?
Yes.
Yes.
Cool. I have always had muscular dystrophy. I didn't realise it until I was about 28. And so I had to go through some significant changes quite rapidly. Just to keep it short, assistive technology is really got me through the bulk of it. But I feel like now I'm at the point where I need a little bit more than assistive technology to help me get by. The things that I've counted on are not as helpful as they were 12 months ago. Obviously the chair and everything is still great, but yeah.
And if there was one thing that you could change in the system with your neurologist or with the way things work, what would make a difference to you? Do you have a concept of that?
Accessibility, actually, at the moment, because I've cancelled all my hospital appointments because I can't get there.
Yeah.
So I'm not seeing a neurologist or a respiratory clinic or a cardiology or the diabetic clinic or any of that.
Is that transport, Andrew?
Yeah. Okay, guys, really sorry. We've got 4 seconds before this session is going to end. So